Good evening, everyone. How are we doing today? Can we hear me, please? Okay, thank you. Thank you. Thank you. Okay, so quickly, we're going to be starting in a jiffy. So I would like someone to quickly give me a summary of what you picked from last session. If you want to speak, please, you can raise your hand. Can we hear me? Okay, thank you. Ibweke, Ibweke Nkechi. Nkechi, you have the floor. Please, you can speak. Quickly, please. You can unmute yourself and speak.
Good evening, everyone. Okay, I learned from the last session, and she said misinformation spreads through emotions and repetitions, not facts. She also said for you to build trust, trust is built by tone, timing, transparency, and it's not just built by your title or the degree that you have. Thank you.
Thank you very, very much. So today we're going to week 3, and I want to welcome every one of us to this session of today. Thank you so much for staying up until now. Yes, and I trust that the training has been very insightful. So today we'll be going to real world applications of health communications. I will be having 2 speakers. I'll be moderating the session. I am Ebine Fivo Uluwadamlola, and I'm the moderator for today. Our speakers today are Dr. John Afam and Dr. Nnamdi Okoro. So we'll be having the citation of our first speaker right now. Dr. John Afam, our topic is doctor-patient communication. Dr. John Afam is a specialist anesthetist, educator, and digital strategist, passionate about improving healthcare communication and professional development. He obtained his medical degree from the University of Benin and received his diploma in anesthesia training from Ahmadu Bello University Teaching Hospital Zaria. He is currently in senior residency training. Sorry, please. Okay. He's currently in senior residency training in anesthesia with training through both the national and West African postgraduate colleges. Dr. Afam has extensive experience managing high stakes medical scenarios where clear and effective doctor-patient communication is crucial. Beyond clinical practice, Dr. Afam is a leading voice in medical social media with over 27,000 followers on Twitter at Dr. John Afam, and that's his handle, where he shares insights on healthcare, leadership, and communication. He has served in key leadership roles within the Association of Resident Doctors, ARD, and the Nigerian Medical Association, NME, advocating for improved healthcare systems and medical education. With a strong focus on health literacy and patient-centered care, Dr. Afam is committed to equipping future doctors with essential communication skills for both everyday practice and emergency response situations. With our virtual round of applause, can we welcome Dr. John Afam? You have the floor, sir.
All right. Hello. Good evening, everyone. It's a pleasure to be here, and thank you for the warm welcome. I think that was Favor who was speaking. I've already been sent the program for this, and I understand that we have another session coming up by 6. This means that we will try and be timely. I'll try and run through my presentation in around 30 minutes. So we have some time to discuss because doctor-patient communication is definitely something that is very important. And at the stage that we're in as medical students in one capacity or another, you are already bound by some of the tenets that we would cover in this session. So thank you all for being here. Thank you all for being on time. I would suggest that if there's a general group where we are in, you can put up there that we've started so that more people can join in, because this is a very important conversation we'll have today. I also want to commend the leadership of the Nigerian Medical Students Association. I know they are involved in this, and the EO Health Hub. I am familiar with Dr. See me calling him doctor. Well, Mr. soon to be Dr. Emmanuel Owolabi, and well done to him and everyone else who's involved with this. Trainings like this are very important to keep our knowledge where it should be. Remind ourselves what's important and also help in our day-to-day understanding of what is. So without further ado, I'm going to be sharing my slides, and do not bother too much about what's in the slides. At the end of this, I will be sharing a document. I'll be a PDF document. I'll be sharing it through the leadership, I reckon, so that we have a copy of everything we've said today, and we'll have it as a reference point for our own day-to-day practice. So before we start, just to make sure I'm not speaking to myself, put up your emojis, say hi. I think one or two persons can unmute and just say hi, so I know that we can hear us while I get in. No, if your hand is up, you just unmute, say hi, so that I'll know that people are hearing me. A bunch of people are raising their hands. All right, let's get into it. Doctor-patient communication. What to say when every word matters. I am going to, again, there's a lot to discuss today. I'm going to preface this by saying, as much as possible, everything is important. There's nothing I'm going to say here today that's not important. There's no part of this lecture. Personally, I don't think 1 hour or the actual time that I'm being given, which is around 40 minutes, is enough for us to discuss this. However, we will do our best. So please just pay attention. Also, all questions will be taken at the end. And like I said, do not reason that you are quote unquote not yet a doctor. As a medical student, there are even elements of this that already apply to you. And sadly or not sadly, this is not a conversation we'll have a lot in the classrooms. A lot of the conversations generally around your medical practice will be more on your clinical skills or your medical skills. But communication is also a very important skill, which we are going to talk about today. So effective communication is central to safe and trustworthy medical care. Take note of those two words, safe and trustworthy. So it's not just about the care that you're giving. Do your patients trust you, and are you safe? This is also important, very important. It forms a crucial bridge between clinical experience and clinical expertise. And this presentation will explore communication strategies to enhance your interaction with patients, especially in high pressure situations, because I understand that this is in the context of emergency response. So we'll talk about that to briefly touch on that. Okay. So communication is not a soft skill. A lot of times we just say, oh, What are the skills you should have? Oh, you should be a great doctor. You should have this clinical skill. You should have that clinical skill. You should have this. You should have that. And then after all this, you now start listing other things that are important. Oh, you should be able to communicate. You should have leadership skills. And generally, these things are regarded to as soft skills. So now I'm not here to say, oh, English, it is hard skill, it's not soft skill. It is more the fact that people think that soft skills are quote unquote less important. This is, if there's one key takeaway from this lecture, it is that it is not. Having the ability to communicate to your patient and patient relatives is almost as important, if not more important, than being able to know what the diagnosis and treatment is. Whether or not you know that I have malaria, if you cannot tell me that I have malaria and give me an actionable next step to malaria, everything you're saying is not really important to me. So a lot of times we push communication to the back because you want to know the 200 causes of fever in an adult or the 20 causes of anemia. Great, because those will make you good doctors and great doctors. It's also important to understand that everything that you diagnose will eventually be said to a patient or to a patient's relative. So if you do not understand what that process is, you're shooting yourself in the foot even before your medical practice begins. Okay? Okay. It's also important to understand that doctor-patient communication is a very common cause of medical errors. In a lot of ways, a lot of variations, this can occur. Oh, they did not explain to me the surgery before I went in. I did not give informed consent. I did not know that was what they were going. Yes, they said it, but I did not know. You understand that consent or informed consent or parameters or statements like that is not just to be said. When we explore some medical legal reasons, you will understand that. But know that communication or the extent or the beauty, the great communication is implicated, rather poor communication is implicated in a lot of medical errors, medical malpractice cases, medical anything that leans towards the side of, oh, problems with your degree, problems with medicine. Know that medical doctor-patient communication is there. So very important also to take very seriously. It's also very important to know that a lot of times, for anyone who has been like a patient, I have been a patient. I've been on admission in my alma mater when they were reading my citation. Yes, I was on admission in UVTH for a while. And if you have not been a patient, sometimes it will be hard to understand what patients go through or patients or patient relatives go through. In your mind, oh, they've come to the hospital. It's you that came by yourself. So when I ask you, even if I ask you 10 times that you should come and tell me the history, you should do it. And once I come, I tell you I'm a student. Even if it's in the middle of the night, I just was admitted. I'm still looking for money to pay for my test. It doesn't matter. The moment I come and tell you I'm a medical student, just stop everything you're doing and start giving me the history. A lot of times, understand that there are emotional aspects to these interactions, whether as a medical student, as a doctor. There are emotional aspects to these interactions. And a lot of times, that is the part that the patient remembers. Yes, they will go away with one, oh, I have this, I'm going to do this for this. Oh, I have an appendicitis, I'm going to have surgery. But they will also very strongly remember, this is what the doctor said. This is how they said it. They said it as if it was my fault that I didn't come to the hospital. Oh, they said it as if they were going to take care of me and make me feel better. It is very interesting how this actually affects our practice. So even things like, oh, the patient was not cooperative. They didn't give me the history that I wanted. Did you speak to them well? Did they understand the needs to give that history? Oh, they did not take the drug. They signed against medical advice. They did not allow me to examine them. Are you sure you had the back and forth? Did you just go there and demand this thing because of your right? Did you take into context what their emotional situation is and put that together? Very important. The third point is that communication is equal to safety. Especially in emergencies, even like, oh, taking next steps. What should we do next? This is what you should do. You're talking to a patient who is in an emergent situation. The clear, calm tone which you talk about next steps You are in an accident situation and you cannot clearly communicate that, oh, we need to get this patient like this, we need to get this patient to the hospital. Know that communication comes in a bunch of ways. We're just talking about doctor-patient communication, but it also cuts across, oh, relatives taking charge of the situation, lots and lots of things. The point of this slide, however, is to understand it's not just a soft skill. It's something that's central to your skill as a medical student and as a doctor. Okay, so in the special context of emergencies, what are the points we should note in communication? First is, and this is not just for emergencies, again, we're going to be talking about doctor-patient communication. There are too many aspects to talk about it, so we'll talk about as many aspects as we can. Now we are talking about those aspects of communication that are especially important in emergencies. And know that emergencies are a range of things from, oh, you're on posting and they urgently present a patient that maybe had an accident or is bleeding out or suddenly collapsed. It can be in your school and a medical student, your classmates collapsed in front of you. There's no doctor there who's supposed to take responsibility. You can be going home or coming home, you can be traveling somewhere, something collapsed. Like, know that even at your level, you have more medical knowledge than a lot of average individuals. This gives you an innate responsibility. You have already, quote unquote, chosen your path to save lives. So that understanding means that even in emergent situations, you should act and act to the best of your ability. Okay? Okay. So one of those points is to speak early and clearly. Medicine and health, like all things, are rather time bound. If you need to get someone to the hospital, or someone needs an urgent x-ray, or someone needs an urgent treatment, there's a time bound element to that. So be very clear what directions you're giving and what explanation you're giving. Oh, this is what is going on. This is the information I have. This is next steps. Use simple language. This is also another thing. I'll tell a bit of my story later, but this is also another thing that's very important. Know that when you're speaking to patients or speaking to anyone else, really, you're not speaking to me. You're not speaking to your professor or your consultant and trying to impress them with stuff. Nobody cares what desaturation is, or okay, cardiac arrest is now mainstream. But what's like that? Oh, he had a what they call it, spontaneous bacterial peritonitis. Big words. What does the patient like? What is wrong with this? Simple language. And we'll talk a bit more about all these things like body language. How's your tone? Do you sound scared? If you are the one treating me, if you're my doctor and you're sounding like, the patient is already going to die, what do you want me to take away from that? So simple language, firm tone, and eye contact. That's also another thing that helps. Understand that whether it's doctor-patient communication, it's still communication. So all those things that help your day-to-day communication. When you're speaking with someone, do you have gestures? Are you gesturing appropriately? Are you in the emotional state where the person, like the conversation you're having, is it the conversation you should be having? Are you very clear about the words you're saying? Are you using the right words? All these things are important. The other point is to repeat and reinforce. So there are many strategies we'll talk about, and we'll not be able to talk about all of them when we're talking about this. But one thing, this comes in many different words. Chunking and checking, ask them back, a lot of things. But the key tenets or the key points that I want to pick away from this is that when you're speaking to a patient or anyone where the balance of knowledge is, oh, you're a medical student, a final year medical student, or a fourth year medical student, and you're speaking to a first year medical student, a first year nursing student, or even, like we said, a patient relative who doesn't have that understanding of medicine or health. Remember that knowledge goes from known to unknown. So yes, I know that the patient came to the hospital and the belly was paining him. That is what I know. You are now the one to translate that information to something I can understand. Oh yes, so the belly was paining him and we did an examination and we found out that, oh, there's something in the belly, that's a small organ in the belly called the appendix, that's part of the intestine, that is inflamed. So that is what is causing the belly pain. We'll give him some drugs for pain, but what we need now is surgery, emergency surgery before the small thing ruptures and causes more problem. Do you understand what I have said? That's chunking and checking. You've given them a chunk of information, and now you're checking, do you understand? So it's things like that, again, that will very easily help your doctor-patient communication. Things like that that will even help your day-to-day communication when you're taking history from the patient. Do they understand why you're asking your questions? That is something that really, really helps when you're having this conversation. So chunk and check, repeat, reinforce, very important. At every point, when you're communicating in emergency situations and other situations, the patient or the patient relative at every point has to be following you. Do you understand where I am now? Yes. At any point you don't understand? No. Okay. Okay. We already talked about using simple language. We'll avoid jargon. That is very clear. So on a personal note, I have always been a quote unquote well-read doctor. I say well-read because books, joined international communities early. Earlier, they still said how I was leadership roles in ARD in this, international roles too. So there has always been that interaction between, oh, this is where you are supposed to be as a first-year resident, as a second-year resident, not just on a national scale, but on a global scale. So one thing mentally that usually just go to my head is, oh, this is the right thing to be done. When you see a patient, you give them all the information that they need, and then you let them decide the treatment. The truth is, like I said, patients don't even need quote unquote all the information that you want to give them. Please know that they need all the information. But there are some things that you even want to say that the patient is not particularly interested in. Things around medical jargon, big words, confusion, things that scare. Like at every point, understand that you're giving information. You're not projecting. Do you understand? Like there's a difference between I'm telling you something to make you scared. I'm telling you something so that you will know. I'm telling you something so that you would understand. I'm telling you something so that you will accept treatment. I know there was a time this matter was trending on Twitter, for those on Twitter, about how when you counsel a patient, you should persuade them as much as possible. I think I was talking about patients with um, religious beliefs that affect their clinical treatment. So patients like Jehovah Witnesses who have concerns around blood and blood products. So the tweet was like, oh, you should do your best to convince them and make sure that you explain to them all the things that will go wrong. On one hand, yes, you should give them all the information. On the other hand, your role is not to convince them to take blood or to convince them to accept your treatment. It's a mistake that doctors make, and it's just important we mention it here. Your role is to give them information, not to scare them into the direction that you want. A patient tells you they don't want blood or they don't want to be admitted. It is not your decision. You think that they will do better admitted, or you think that they will lose their life if they don't. It is not your decision. Your decision or your point is to give the patients all the information they need and counsel them on the plus, minus, these are the pros, these are the cons, these are the issues, these are the concerns. I'm saying this again as a piggyback of this because it is important to understand this difference. You are a doctor, your duty of care is to the patient, and the patient has a right, the ultimate responsibility of, oh, what should happen to my body, what should be done to me is with the patient. So don't forget that. So again, like I said, this really came to fore when a relative of mine was admitted. And I found out that it's not really about, oh, do you know they moved to the ICU? Do you know that the patient is on CPAP? Do you know that the patient had hypoxia that is resolving? The information that they want is not jargons. They want information that will help them understand what is going on. Oh, the oxygen, the patient was not getting enough oxygen, but now we fixed that. We're still touch and go for the next 24 hours, but we would watch and give you updated at every moment. This is just a quick point to mention that communication is not one-off. At no point is communication one-off. Oh, you're going in for emergency surgery. I've told you now, and that's it. 1 hour into the emergency surgery, what is the update? If the patient wants updates, they have the right to know. Oh, surgery is going to last around 2 hours. At the end of 2 hours, patient is not out of surgery. You're not saying anything. What do you think they will think? So information is continuous. Oh, this is where we are now. I'll give you updates as soon as we have some. Understand that it's not jargons. It's not this. It is information. Doctor-patient communication is generally around giving information to the patient relatives. And like I said, understanding that they are going with you. Very important. So let us now talk about the patient. Some things that make this communication difficult, especially from the side of the patient. Now, patients, especially in high stakes emotional situations like both emergency scenarios and medical scenarios, there are lots of concerns with information around that time. For example, I'm an anesthetist. Not all, for those who know, definitely not all anesthesia puts the patients to sleep. But you cannot be coming, oh, because you did a regional block, and coming when the patient is on the table, which is a high stakes emotional situation for the patient. But just because, say, the patient is awake, not drowsy, not under anesthesia, or not under general anesthesia, you start maybe expecting to take consent for the patient for a different procedure, or inquiring, like taking information across board as to what or when, what is the most appropriate way to communicate with patients. Like we said, hospitals are a high stakes situation. There's nobody that's coming to the hospital who doesn't have some form of emotional involvement. They are sad, they are angry, they are happy that they came early enough, or maybe they are happy that their father, who fainted in the house, has gotten to the hospital, they are getting better. Or they are angry that, oh, the uncle that they're intending to take drugs. Point is, there's always an emotional component. It is very important to understand this when we are dealing with doctor-patient communication. Again, phrases like, when we talk about medical jargon, know that a lot of things mean a lot of different things. We talked about saying something like, if I tell you now, oh, the patient is stable, you probably understand what I mean. But to a lay person, a patient relative, this probably doesn't give the same meaning. What does stable mean? Stable means it's going to get better. Stable means that there's nothing you're doing for him. Stable means, so lots of things, but there's an uncertainty that comes with medical jargon. So we talked about it earlier, but very important to give all the information necessary and explain as clearly as you can. We've talked about using medical terms, everyday language, very important. Finally, when patients are under stress, not just patients' relatives, when they are under stress, you understand that most of the things you say will not be understood by them. You see it a lot in movies where they say, oh, doctor, no, don't tell me anything else. Is my baby going to be okay? How am I not going to tell you? Do you understand? Like, how will I tell you whether your baby is going to be okay if I don't explain everything to you? But that is how it is in real life. Nobody wants to hear your long story when you're coming out of the surgery. Oh, yes, your baby is going to be fine. This is what went on. This is what went on. Like we said, remember to chunk and check. Do you understand what I have said? Because at first pass, when you finish saying all these things, if you don't reinforce, if you don't understand what's said, if you don't go back to ensure that the patient or the patient relatives understand the various scenarios you painted for them, they will only hear, oh, the doctor said the baby is going to be fine, but that they open, like, you will hear the most discordant things, which again is why it's important to ensure that you go through the processes. Okay. So enough about patients. Let's talk about talking to families. This is including patients' relatives too. Especially as medical students, it's important to be honest and careful. Careful, very important. One of the most recurring terms in generally medical practice or anything like that is how you should first do no harm. I'll say it again, first do no harm, which means that as a doctor, as a medical practitioner, whatever you're doing to a patient should not be harm. If a patient has a concern and you're giving them false hope, you're doing harm. Like we said, your duty is not to lie to the patient. Your duty is not to make them feel better in this context. Obviously, yes, you treat them and help their health get better. But it's not to tell them oh, I'm too afraid to tell you the truth that you're going to cut off your son's leg, so let me lie to you. Don't worry, everything is going to be fine. Who are you helping? So be honest, very important. Do not think that all the things we've said about empathy, about passing information correctly means that you should lie to a patient. Please, no, never. Because at the end, you ask yourself, to what end? If a patient if a patient or a patient relative, you're counseling them about the outcome of the surgery that was not successful, or for example, there was an untoward event in the theater, you're giving them bad news. You're painting the scenario as less important or less difficult is not helping them at all. So deliver truthful information with sensitivity. Another thing I'm going to say about care is be careful what you promise. I think generally as you grow in your medical practice, you would understand that you can't make promises, especially in our client. Please do not make promises. Oh, he's going to be fine. Oh, I will do my best. We'll do our best to make sure we get him everything. But if you do not know that the patient is going to be fine, please do not say the patient is going to be fine. So again, doctor-patient communication is an evolving thing. You're not going to know how to do all the communication today, but it's very important that you pick up these important skills. Be honest and be careful. Very important. The second point is to understand that silence is a part of the conversation. Silence is a part of the conversation. You cannot just bust out, hey, how is my uncle? How is my uncle? How is my dad? How is my dad? We did our best, but he didn't make it. I'm so sorry. And then you go away. Please. Please. Didn't make it is even too far. Oh, yes, you brought him, but you didn't bring him on time. He's going to the theater. We are going to do surgery on him. And then you walk away. So at every point, understand that you are giving very important information. And like I said, silence is part of the conversation. Do not say everything once. We talked about chunking and checking. There's a rhythm to this thing. There is, like I said, when I'm sending the reading materials for this, we'll give a few scenarios or a few strategies for having this conversation. Things like spikes. I'm sorry people have heard it before. Set the mood, inquire how much they want to know. All that will be in the reading material. But please, like I said, know that there's even a space for you to pause. How are you? Also, please, that's also another thing. Do not start with the information. Who is the person that you're talking to? Oh, are you okay? What information do you want to know? Is my baby okay? Yes, your baby is going to be fine. Or yes, we're doing our best, but this is the information I'm here to give you. This. Again, any answer you give, ensure you are honest, you're careful, and there's that pause that allows them to ask the next question. Even if you're delivering bad news, there's that pause for them to understand what you just said. Like I said, you can't just come out, tell someone they're going to surgery and bounce out. They have questions. They even need time to let that information enter into their ears. So very important. Reassuring phrases. I've talked a lot about our duty of candor. Very important to be honest, important to be careful, important to not give false hope. Also important to not give patients, to remove the hope that patients have. Again, you can see that is a balancing game. How much do you say without being dishonest? You know that every surgery carries a risk of mortality. But will you tell everybody that, once you enter this theater, you can die? So at every point, there's going to be a balance. It is your experience that will build this balance. This experience is not even just clinical. It's also cultural. There are ways that you talk to people in different cultural settings. A chief cannot come and you tell him, strip down from head to toe. We want to examine you, chief. So again, this might vary from your setting to setting, but it is the truth. You cannot see a respected your consultant cannot be in theater, be the patient in theater, and that is the day that everyone is coming in, going out, we're taking this, we're doing content, but no, there is trust in this, there's empathy, there's a lot of consideration that comes into communications. any form of interaction between patients, there's a lot of consideration that comes into it. So like I said, we cannot be dismissive. You cannot be dismissive of patients' concerns, but you can also not be extremely critical. Oh, if you don't have the surgery, you will die. You. How did we get there? There's an explanation to it. Oh, this is what will happen if you don't have the surgery. And this could happen in this will happen in this. This is the treatment now, and this is the. So at every point, please know that, like I said, while you're not there to make the patient feel better about whatever condition they have, you're also there to reassure them so they do not feel despair. So they have the mental capacity or the mental strength to go through with that. If you're already telling someone who's going to surgery that, shall know that there's a chance that you will die, the person will say, let me be managing the leg like that. I mean, it's broken, but make a day. So at every point, it is a balancing game, a very important balancing game that you will get better at the more you practice, the more you see patients, and the more you understand that doctor-patient communication is not just, there's a skill to it. Very important. Another point is to ground yourself. Grounding yourself means that, like I said, you understand the scenario you're in. I just want to put one point about safety. Please know that anytime you're having a medical conversation, especially one that might not be great news, it is very important to first be safe. I'm just going to quickly add that there. Whether it's emergency scenarios or in the hospital, they bring in a man with machete cuts all over the body. The people who are bringing him in are holding machetes, very angry. The man has passed on. He's there. You want to start counseling. How did you bring him here? Who caught him? Who did this? Let me not say anything bad, but yes, oh my dear, it will not end well. You hear stories of doctors' assaults, and anytime we talk about it on the doctor side, one of the things we'll say is ensure your safety and clear communication. If you cannot talk there, if you can't have this conversation there, know that you need to be alive to counsel patients. It's not the other way around. Counseling doesn't come before your safety. So you hear even in emergency situations, when they are doing ABC of resuscitation, when they teach people, they'll tell you, ensure safety. You cannot be resuscitating a patient in the middle of the road, Then another car will come, knock you down and knock the patient down. And then, so at every point, are you safe when having this conversation? In fact, when we are talking about spikes and how to deliver bad news, you hear things like, make sure you are seated closer to the exits than the patient. Make sure you do not have your tie or any tight-fitting material around your neck. I'm seeing emojis about laugh. I'm serious. So this is actually like in the handbook. Like I said, I'll send it to you people. But real matters. Have the conversation. Ensure the patient is seated. Ensure you are seated. The patient cannot be at the exit and you are inside. Then the patient blocks the exit. You have nowhere to go. So there are lots of considerations. Doctor-patient communication is something that will be part of your life even from now, because you go to the hospital and you speak to patient relatives. Is it when, like I said, I just came back from surgery, I'm trying to settle my patients that I came, they've told me to go and buy blood for another blood, maybe patient lost blood. That's when you want to sit me down because you have ward rounds tomorrow. I should come and give you the history from when we came. So again, is this the right time? Is this the right environment? Are you safe to have this conversation? Very important. Okay. So, culture, class, and communication. We have to run through. I just realized that we've taken some time. So, very important to know. Like I touched a bit on culture earlier. There are lots and lots of angles to cultural communication. From the way we treat our elders, very important. Please do not. Again, like I said it a bit in my story when I talked about how I'm trying to be an international doctor. I forgot that I'm practicing in Nigeria. So very important. There are certain ways we relate to certain cultures, certain cultural norms that are with us. Do you understand? Like a patient comes, like I said, there's still that respect you give. Yes, you're in the hospital, but there are certain cultural expectations when you're talking about pregnancy, for example, or childbirth, for example, there's a cultural expectation that you should have the conversation with the father too. Note that, again, this is where, let me not go into a gray area, because it's around consent and who gives consent. Obviously, again, it's the patient that your duty of care is to. But this is, like I said, what I'm saying about cultural expectations. If you go and finish having the conversation, and at no point did you tell the woman, oh, maybe I can speak to your husband if you want, or let your husband be here when I'm having the conversation with you, and the man is telling you, you did not tell me anything. No, the man has a right to know. So at any point, understand what the cultural nuances are. Some expect formality. Some expect you, how can you be telling me this? Some expect that, you will tell I brought my child that is 16 years. How can you be counseling my child that is 16 years when I'm the one paying the money? So whatever considerations are there, very important you take it into context. However, know that your duty is to your patient. In our climb, there's that patient-child balance. So there are now special considerations where you're having a pediatric patient, you have some duty to the parents. But always know that your first duty, you cannot be giving details. Oh, sorry, I'm just going to add that, because like I said, I can see that we are closing in on our time. I'm just going to add that you cannot be giving details. When we talk about doctor-patient communication, remember patient's confidentiality. It's not everything that you can tell everybody. It's not everything you can tell all patient relatives. In fact, you should ask the patient, which of these things do you want me to tell? Do you want me to tell them that you're pregnant? Do you want me to tell them that you have HIV? Do you it is their decision. I say this because, again, it might be difficult to understand or to enforce, but very important to know. First, your duty is to your patient. And there is a point in all this outside doctor-patient communication that talks about doctor-patient confidentiality. There are some things that your patient will tell you that you cannot tell anybody, except, again, under special considerations. But that's not even what we are dealing with here. It is not your duty to inform your patient's husband that she has HIV. Please know that. Again, like I said, the entire concept of your doctor-patient communication will continue to evolve. The more you practice, the more you see patients, the more you practice across clients. I practiced in Zaria before I came to my current situation. The way we deal with patients there was even a communication barrier on my end because I couldn't speak Hausa. And most of the people there were speaking Hausa. So all these things add up. But again, remember quickly, since I've not mentioned that, doctor-patient confidentiality is a thing, and it's something that could lose you your license. So whenever you're having the conversation, whether communicating with patients or patient relatives, remember that your first duty, and basically your only duty, is to your patient. Okay? Okay. So also to add that non-verbal cues count. You are talking about that, a patient is dying and you are folding your hands, that there's nothing else you could do. You don't prop for one corner as the jagaban where you be. So I'm here to tell you, folding your hands, looking haughty at patient relatives. So I want to tell you that patient had an arrest again. We brought him back, but he's now on the ventilator. You are telling them that, the man is critical, the man is probably not going to make it. And you're non-verbal cues count. Whether or not you are sorry for the patient, whether or not you feel empathy, please know that it's your expectation as a doctor. You should feel empathy that a patient is passing on, that a patient is critical. If you don't, please do. Please do. Please do. You need it for your practice. So when you're saying this about the patients that you feel bad for, you can't even say it with a straight. You can't fold your hands and say it. If you have empathy for your patients, there is a way you would say it because you know what it means. You understand what it means if you're telling someone that their sister is probably not going to talk again. So at every point, know that non-verbal cues are very important. The way you stand, the way you're saying it, the way your posture is, all these things, very important. Okay? Okay. So a point about the digital patient. Digital patient. Now, I do some work on social media for those who know. I know that a couple of people had already tagged me today when I put up my post. And I'm just going to say, by the way, please say hi. After this class, you can maybe take a screenshot. You were in the class, say hi. Very happy to connect. In fact, that's the easiest place where anyone will be able to connect with me. So Twitter handle is as usual at Dr. John Afam, Dr. John Afam. So, oh, I was in the session, happy to connect. Please, I would encourage all messages. And I really like that social media because it's my way of connecting with you and your way of connecting with me. So, digital patients, why is this important to say? It's important to say because we are in a new era, the era of digital. A lot of the realities that you people are going to face now maybe didn't exist or didn't exist in so much didn't exist to this extent in our time. No one was going to tell you that they've asked Chat GPT for their symptoms and this is what you should treat for, or get it with that amazing accuracy. Because also know that, oh, these patients are also more informed. You cannot come and bamboozle a patient now. Just take it as I have said it. Patient will Google it and tell you that you don't know what you are saying. And it will be very funny. So understand that your patients are digital. This means that first is a challenge to you that your medical knowledge needs to be top notch at every point. This is why I also encourage as many people as want to hear. Please embrace your digital tools. If you don't have Medscape on your phone now, what are you using your phone to do? But you have Instagram. You don't have I don't know what Medscape used to be the end all be all on our phone because that was a complete compendium. You don't have your textbooks on your phone, but you are please, you should have like the digital, like what are the digital tools that you are using to improve your medical practice? If your patient already has access to this, you with your own superior knowledge should be much better than them. Okay. So when a patient comes and tells you, I Googled it, oh, this is what it says, please be respectful of that patient's knowledge. I say this because a lot of times we see this comment on social media. How can you Google it and come and be telling me, oh yeah, do it yourself now? Sure, you've decided to be the doctor. Please, that is not the greatest approach. I'll never subscribe to that. The patient has a right to be interested in their information. Like we said, conversation goes from known to unknown. Oh, what did you read? That is how it should go. Engage, don't dismiss. Oh, what did you read? Where did you read it from? If there's misinformation there, it is your duty to correct it. Correct it in such a way that you gain the patient's trust. Because you go there, you say, how can you be Googling this thing? Don't Google it, oh. Just go and do what I said. The patient goes and doesn't do what you say. And you say, these patients today, they are so stubborn. But you have not given the patient one reason to believe you. No. It's like going to buy a phone. You go and buy it, you browse by 600K or 500K. You go to the phone store, the person tell you, like, browse waiting in the browse. Don't tell you, say, 800K, I sell my own. No explanation. No, oh, this one has more gig. Oh, I understand that you browsed it, but you know that, oh, sometimes they do. No, oh, this one has a percentage discount. No, nothing. And that is how you sound when you say, oh, patients shouldn't Google. Why shouldn't they Google their symptoms? So understand that in this digital age, the way you can keep up is first understanding that information is available to everybody, your patient or your ogas or your colleague. As you are diagnosing the man, as you are saying, the man is coughing, as you are asking the symptoms, the son is there putting it inside Google and asking, oh, my father has this symptom, doctor asks this is the answer. So use those tools too. That is one. Know that you have to be ahead of the digital game. Second is that digital is not your enemy. That a patient knows if you're intimidated by your patient's knowledge, that is on you, not on the patient. Please take a moment to understand that you cannot be intimidated by your patient's medical knowledge. What do they know? You went to school for 6 years. So your goal should be to say, oh, I understand why you're thinking like this. However, these are the reasons why it's not like that. This is what we'll do for you. This is the answer. It's not to say, oh no, this, and because like we said, those are the ways we block our patient's trust. If your patient doesn't trust you, they will not listen to you. If I don't trust that you're looking in my best interest when you say I shouldn't drink beer, why would I drink beer? Or why would I not drink beer? Okay. So we already talked about using digital schools and tools. So this is also not just for the patients. This is also for you. Use voice notes when explaining to the patients. Simple sketches. You can have diagrams. Oh, you're in your operating room or your consulting room. Open it. Oh, this is what the throat looks like. Or you can see this red patch here. This is like, understand that that patient knows it did not remove any knowledge from your brain. That patient guesses or has information that this cough could be infectious does not remove whether you know it or not. It's for you to be able to diagnose and communicate to the patient. Do not be dismissive. Do not be combative. Do not be, because all these things only alienate you from your patient. And like we've said multiple times over these sessions, as the world is growing digital, our patients are digital too. In the NHS, that's in the UK, they book telephone conversations. This is not even that, they just called the hospital and someone picked. You are booked for a session to speak with a doctor, and it's their phone call. Hello, I had this complaint, I had that complaint, I have this. Then when the patient tells you that, I thought it was this, you say, what kind of thing is that? And shut down on the patient. Please. No, your digital patient is already here. Upgrade to digital. And again, by the side, this also means your communication on social media. I'm just going to say it by the side because the doctor-patient communication on social media is still a very gray area. I've done a couple of threads around what you should say, what you should not say. There are hyper guidelines, NHS guidelines, all that, a lot of guidelines. In all this, remember that you post a clinical picture or you post a clinical story doesn't mean that the people responding are your patients. Understand the duty you have to them. Also understand the expectations when you post such messages. Are you helping the medical community? You have are these questions? Okay. All right. Sorry. Okay, where were we? Okay, yeah. So I was saying that, so when you share content on social media, you share a clinical story or something, it is not, the people responding are not your patients, please. It kind of should tidy or give you some concepts into how you should respond to them. In short, online response and how doctors should respond on social media is an entire course on its own. So we are not going to dwell too much into it. But the key point there is that also know that the things you say on social media, you're sharing a clinical story, maybe for information of other doctors, to connect with other doctors, to share experiences and grow together. Why are you sharing it? Are you sure that you're not breaking your doctor-patient confidentiality? Did you take consent from this patient to share that story? Is this story painting your patient in a bad light? Please no. Please know that even if the patient gives consent and then you want to tell the story that paints the patient in a bad light, that is against doctors' social media guidelines. Patient did not give consent, or patient gives consent for anonymous sharing, and you share, and somehow someone can decode that patient was your patient, or that this is exactly who the patient is. That doesn't portray either the patient or you're sharing this in a proper light. So we are not going to talk too much on doctors and sharing social media content and all that. The key points here to note are that a lot of people will already go through social media. A lot of these conversations will be had on social media. Someone can come and show you a tweet from someone that's not even a doctor. and say that, I had this and I did this, are you going to be dismissive? How can you do that? Illiterate like you. Can you imagine? You should get out of my consult. What are you fighting for? How is that patient going to trust you and tell you tomorrow what they did? So very important to note, you as a doctor, you cannot judge. There's no judge. Like we listen, we don't judge. It's doctors, they said that thing for. Because no matter what a patient tells you, you will swallow it and you will give your best care. Very important. Okay? Okay. So on a final note, because I can see we're already encroaching on our time, I also see we have some questions that we're going to run through very quickly. If you only remember 3 things, remember these. Don't ask, do you understand? It's not, oh, talk. Patient had this, so we did this test. We did this, we did this, we did this, we did this. Do you understand? Patient, the relative says yes, you go. You did not understand. Do you understand? Yes. Or what? Do you understand? Yes. Okay. Can you tell me what you understand so far? Chunking and checking, reiterating. Oh, you talk say you get waiting day in belle where e go shit come out. No. I say you get waiting day in belle where they block where shit they come out from. So we go do operation. That is how doctor-patient communication goes. Your patients do not know it. They do not, if they knew it, they will not come to the hospital. They will do it at home. So know that you have a responsibility to be clear to them. What's the second point? Stay calm. In all this, you have to be a reflection of the care that you're giving. If your care is agitated, you come, this is what we have to do now. You run back. You come again, always in a hurry, always not knowing what else. No, you are the one who knows. You are the one who's telling the patient or the patient relatives. So you stay calm and have a steady voice. Be very clear what you're saying. If you don't know, you don't know. Oh, we are examining him. We would know more very soon. But this is where we are now. Very important. Be very clear, calm, steady. What else? Treat communication as a clinical skill. The only skill that you are going to have is not whether you can intubate or not, or whether you can sorry. So the only skill you have is not whether you can intubate patients or whether you can put up a line or whether you can do this. Can you speak to the patients? Can you say what you want to say to the patient? Does the patient understand you? If not, you're far away. Okay? Okay. So what else? I think that is it. So focusing on this point will transform your interactions and will improve patient outcomes significantly. Okay? Okay. So like I said, at the end of all this, we're going to share, or I'm going to share I'm going to share the notes for the class. And I encourage everyone, doctor-patient communication, like I said a couple of times across this, is something that will continuously evolve. It is something that you will continuously get better at. It is something that will evolve every time you see a patient. Every time you see a patient, the same way you ask yourself the clinical questions. Oh, what is this patient suffering from? Oh, how are we managing this patient? What is the clinical plan for this patient? Ask yourself also, what is the how am I communicating with this patient? What does this patient know? What have I said to this patient? Okay. I think we are all good. I know there are some questions there, and I keep hearing a beep. I wonder if that's my time. So, Favor, hello. I think we're here.
Thank you very much, sir, for the wonderful teaching and session. Yes, it was very, very much points, actually. Okay, yes, please, let's give him a round of virtual applause. So we'll be going quickly into the question and answer session. We have about 3 questions on the group, which we'll run through quickly. So the first question says, concerning do not give false hope. That's from Uzoma Mesoma. A family medicine lecturer said it's not right to tell a lady that just delivered that baby has died. So is it right to tell a woman that just delivered that a baby has died when she asks about her baby? That's the first question.
Okay, so I can see the questions. I guess I'll just, because I also see that we're pressed for time. So I'll just read them and answer them. Let's not be doing the back and forth. Is it right to tell a woman that has just delivered that her baby has died when she has a baby? There are multiple. Okay, so I would, most of the answers to these questions will not be yes or no. I will give you scenarios and I'll give you systems, because none of your two patients will be the same. A patient just gave birth. She's fully conscious, oriented in time, place, and person. She understands that she has had a difficult pregnancy prior to the maybe CS that she had self. Prior to that, you were already managing for fetal distress. You had counsels that you are doing the emergency surgery because of fetal distress and that you were finding it difficult to pick the baby's heartbeat. This woman has delivered, the woman is doing well, and the woman inquires. Do you think you should tell her? Shouldn't you? Again, understand that there are very many scenarios where this can occur. If the patient is unstable, maybe hysterical, has had a difficult CS, you fought 6 liters of blood loss, patient is in the ICU, in and out of recovery. The patient asks, is my baby alive? You will tell her yes or no. You will tell her you are taking care of her. Get better first. We will continue to look after. Don't worry, we'll call some of your relatives here to be with you in on this time. Again, the point of my answers, my two answers, is for you to understand none of your two patients will ever be the same. No two patients will ever be the same. So there is no hard or fast rule to everything. But we'll examine some of the things that we've said in this so that you will answer that question. Know that first, like I said, your duty is to your patient. Whether or not the patient doesn't know now, you will not tell the patient tomorrow. You will not tell the patient in 6 hours' time. When you say that the baby just died, is it 6 hours later? Is it 10 hours later? At what point is enough? So there are a lot of other considerations. Is when we talk about spikes. Is the setting appropriate? Is it when you are still in the recovery room of the CS that she just came out of, you are telling her that the baby died? Which kind of medicine is that? So again, there will always be lots of considerations, lots and lots of considerations. But what is guiding you? Your duty, your patients, the duty of honesty that you have. Why are you telling her that her baby is there if her baby is not there? Why are you telling her her baby is not there when she's not even in the mental frame of mind to talk about her baby, when you are still battling with whether her BP is going to go down or go up? So across board, it is not just, the question is not, should you tell? Why won't you tell? The question is, when should you tell? How should you tell? Is it the right time to tell just because she asks? That's that point I said about that. It's not everything that you're going to tell a patient at every point. Do you understand? You have to give them all the information, but where you are giving this information is important. How you are giving this information is important. The clinical scenario, is it the most important thing that she knows the condition of her baby at that point? If the answer is yes, why won't you tell her? If the answer is maybe not immediately because there are other more pressing issues, why are you telling her? So across board, I hope that answers the question. The truth is there are no hard or fast rules to these things. There are situations we've been in theater and it's like, oh, we can't tell the mother that her baby is not alive, at least until she gets out of theater, gets to the ward. You are intra up, you want to tell her on table there that the baby will live her. You go do 2 CPR and it will not be funny. So I don't, obviously, please know that the jibes I'm making is not to trivialize these things. You're dealing with lives. But your responsibility, that's why, like I said, doctor-patient communication is continuously evolving. There is no yes or no answer to this. I can say no because you need to protect patient's mental health. Can also say yes because it's the duty of candor that you have for the patient. But that answer will vary depending on who the doctor is and what the scenarios are. But please know that eventually there is no excuse for not telling the woman. If you say, oh, I can't tell her now because she's still recovering, she's not in the greatest frame of mind, when did you plan to tell her? It's not that you went home and decided to forget that you had a patient, what is your responsibility? What is your plan for telling her? Do you understand? Okay. So in pediatric patients, who's your first duty to? For example, a Jehovah's Witness who doesn't want blood transfusion, even when your child's life depends on it. Again, this is a medical legal question, because in Nigeria and all over the world, children are under the direction of their parents. They can't take consent to their parents take consent for them. And things like blood transfusion or even treatment of any kind, there's implied consent. If you come to the hospital, for example, you kind of have given implied consent for me to ask you questions and to examine you because you presented to the hospital. Abi? But for something like blood transfusion or surgery, you need written consent. Okay? Oh, yes, I have counseled you to take blood and you have agreed to take the blood. So if you've counseled the patient and, okay, before we talk about pediatrics, you've counseled the patient said you're not taking blood. Like I said earlier, it's not your duty to convince them to take blood. It's your duty to counsel them on the pros, the cons, what will happen if they take blood, what will happen if they don't take blood, and to document appropriately. And in certain cases, to refer upwards too. As a resident, this is not my decision. It's probably my consultant's decision. So I will now refer, Chief, the patient says not taking blood. Oh, okay. Have you counseled this? Okay, let me counsel the patient. I will write this. So understand that there are layers to it. Now, for pediatrics, if a patient is on the brink of life and the patient needs blood to survive, the pediatric patient, there is some precedence actually, because I think a landmark case has been won somewhere in Lagos State where basically the court ruled against the family that that the doctors have the right to give the patient blood. Please know that this is under strict legal guidance. It is not just, oh, I counseled them, they said no, I decided that, and I gave blood. No, there's a protocol to it. If your hospital has a legal practitioner, that person has to be involved. Most hospitals have lawyers. So, oh, your lawyer, the hospital lawyer is involved, the consultant in front of the case is involved. It's not a medical student or a resident decision. So all these things gives you the legal backing. But yes, there's legal precedence that says that a child, because that's technically the parents choosing whether or not to save the life of the child. Okay, so in that context, like I said, there's a legal precedence that says that your duty is to save the life of the child. But also remember that difficult decisions like that or decisions like that are not at this level. They are at levels that involve the hospital administration, the hospital legal counsel, possibly the patient's legal counsel too. Again, this is, let's say, a different conversation, but long story short, your duty is to save life. And if preference is coming against saving life, in patients that can take that decision, they will take the decision, you will document that you've counseled them, and everything will be fine. If they are not able to take that decision, you would upscale, you would escalate. And then if there are legal interventions to be done, oh, we are going to give the child blood, and those legal interventions are done, please ensure that you follow the right path to get it done. In case where patient confidentiality will put the health of more individuals, they protect the patient's secret. Like I already said, okay, I don't know if you can read the question, so let me read it out properly. In cases where patient confidentiality will put the health of one or more individuals at risk, do you protect this patient secret at the expense of the society? This is one of those well-established medical tenets, and one of the few cases where patient confidentiality is not absolute. So in cases where, for example, there's a pandemic, when we are fighting COVID-19, for example, you as the doctor or patients come and say, don't tell anybody I have COVID. When we know that everybody, please, as a public health concern, no, you cannot respect patient's confidentiality and things like that. Patient tells you they want to go and kill someone and you have actionable evidence that they are going to. No, you cannot respect patient's confidentiality and things like that. So there are legal boundaries to these things too. But for the most basic, please, patient confidentiality is almost absolute. However, like I said, there are legal boundaries to this, which you will get more information on. The more you practice, the more you experience patients. And again, please know that you're not operating in isolation. It's not just you that's practicing. When you graduate as a health officer, you have a reg. Your reg has a consultant. You have a consultant. You have a team that you're working with. It's not a decision that you're going to take by yourself. So that's another beautiful thing about medicine. Okay, in a case where the parent is a pregnant teenager and doesn't want the parents to know, but they need to know because of one thing or another, what do you do in that case? Really interesting questions. Pregnant teenager, if the child is 19, the child has a right to their treatment. Abi, they have no responsibility to the parents. Do they? No, they don't. Or do you? No, you don't. The child is an adult, even if he's 19. If it's earlier, there are other considerations to that. Like I said, there are legal considerations to that. Because if the child is 16 or 17, staying under the parents' roof, and the parents are legal guardians, you do not think you have a responsibility? Maybe. Okay, so to clarify, let me give a direct answer to this. These are gray areas, but these gray areas also, you are not left hanging. Your hospital probably has guidance and guidelines. Your team has a operating framework, and you're operating under your seniors. Your consultant is there. Who has responsibility, final responsibility for these patients? So pregnant teenager that's 19 has no responsibility for you to tell the relatives or anything. Pregnant teenager that is 16 and is going for ectopic because it's ruptured and patient is already in shock, who is going to give consent if not the family? How can you hide that information from them? Because child say you should not tell. The woman is bleeding out in your operating room. So again, you can see that medicine is very dynamic. I'm rounding up because I can see that I've exceeded my time. Medicine is dynamic. None of these questions that has been asked today has a yes or no straight answer, because there are various variations. You see various patients, you have various considerations, various clinical considerations too, that will affect your management, because in all these things, it is management. So thank you all for being here. Thank you for staying from beginning to the end. I think we started with 100 and something. We have around 200 now. Thank you all for being here. I think the last thing I'm going to say is that later this evening by 8, I am hosting a class, Smart Writing with AI. So for people who create content, who write stuff on AI, who wants to start creating content, because the beginner class, you want to learn how to use AI to write on LinkedIn, you want to learn how to use AI to write on Medium, you want to create more content on social, ChatGPT is there for you. It can do all these things and do it excellently well. So join us by 8 and we'll have the discussion. I think at the end of this, I'll just send the link to the group to Emmanuel and he'll share it on the group. So thank you all. Like I said, I know I'm far past my time. Tag me on Twitter, say hi to me. Doctor-patient confidentiality is communication is a continuous thing. It doesn't, he has started, because all of you are going to graduate and become doctors, but it continues every single day. I'm like in my 8th year of practice, and every day there's something new or some new thing to establish or explore when you're talking about doctor-patient confidentiality or doctor-patient communication. So thank you for honoring me with this. Tag me on Twitter. I'm going online now to see all of you's posts. If you haven't posted, please post now. Join in the link when it's sent earlier, and class notes will be sent at the end of this. So,
Thank you very much, sir, for that amazing one. Thank you very much, sir. I am sure every of our question has been answered one way or the other. So our time is fast spent, so we'll be moving quickly to the next thing on our segment. So we'll be welcoming Mr. Philemon Ukane, who is the CEO of Lab Tracker, to speak to us briefly on what Lab Tracker is about. Over to you, sir. You can unmute yourself and speak to us.
Hello, good evening, everyone. My name is ViHLERT, and I am the founder of Lab Tracker. I hope everyone can hear me clearly, correct?
Yes, we can.
All right. So I would like to show my slide. One moment. Can you hear me right now? Yes. Favor, please confirm that you can see my slide. So, I just need confirmation that you can see my slide.
I can't see it
Okay.
yet, but I think others can. I think my network is bad.
Can you see my slide?
Yes, we can.
If anyone else sees my okay. All right. So I'll proceed with my presentation. So, I like to refer to Lab Tracker as the future of medical diagnostics, and the reason being that we are digitizing medical labs in the 21st century. Like I mentioned earlier, my name is ViHLERT. So, an introduction about what we are. We are in the digital infrastructure for medical diagnostics in Africa, and how we're doing that is by connecting patients to better medical diagnostics centers through a seamless platform, which makes diagnostics faster, smarter, and more accessible. Right. You can learn more about the parent company behind LabTracker at islabafrica.com. Let's proceed to why regular testing matters. Considering that most of us here are professionals or student professionals in health, doctors and the rest, we know how vital early detection is to saving lives, right? And then there are a lot of diseases that show zero symptoms until it is very late, until it's at least late stage. That's when it begins to show symptoms. And then we also are aware of the dangers of not testing often, which includes the delayed diagnosis, which means that you get to spend more to treat yourself, and then increased health risks and higher medical costs, right? But then knowing that, it's important to test and all of that, there are certain issues, certain challenges with the traditional testing we know. This includes it's time consuming. Most labs experience long queues and wait times, and then it's inconvenient because you'd have to travel to and from the lab multiple times, and it can disrupt your day-to-day living. For most people, they would go check out the lab if the lab offers the test first, and if that lab doesn't offer the test, they'll have to leave to another lab, right? Or they go to the lab and then they cannot afford the pricing the lab sets for its test. They have to look for another lab that offers a more affordable pricing for that test, right? So no, all the back and forth contributes to the inconveniency that comes with traditional testing. And then there's the uncertainty. You don't know when your result is ready, right? And even when your result is finally ready, you'd have to either go back to the lab or manage your result via different channels, unconventional channels like WhatsApp and email, which can scatter your health data across different channels, and you're unable to manage all of them in one place. Now, this is why you should use Lab Tracker, right? As a medical doctor, or you could tell your friends, your family members that would want to do testing to use Lab Tracker. Lab Tracker is convenient, it's reliable, and it's secure. Right? We know we are dealing with health data, medical records, and we have to make it secure. Uh, and then uh, you can book all of your test needs online, with time, we would include making schedules for scan. For now, it's just medical tests. Yeah, then you can book online wherever you are. It doesn't matter, and you can also schedule at-home sample collection. So if you want premium treatment, I'll put that, and you don't want to leave your home, you can request for at-home service. But if you feel okay, you prefer to walk to the lab to drop off your sample, you do not have the extra fee to pay for at-home sample collection. Lab tracker makes it easy for you that when you arrive at the lab, you're not spending time to wait or queue and wait for your test to be booked. You're already booked. All you have to do is for the receptionist to confirm your order, send you to the phlebotomist for sample collection, right? And then once you're done with sample collection, the result is ready. You receive your result on the lab tracker app. It's online, it's fast, and it's secure. Now, like I mentioned earlier, easy online bookings. You can find and book tests with any laboratory of your choice. You don't need to leave your home for that. And then you benefit home sample collection, online result delivery. And the best part is we've actually partnered with other telehealth consultation platforms to offer you access to qualified doctors for your consultation needs. So for our home sample collection, we'll be sending certified phlebotomists to your home, and then you have the flexibility to schedule the time that fits your routine. And then you can track your sample collection in real time. You know when it gets to the lab and when your testing has commenced. Yeah, so you can download your result on the lab tracker platform and share with whoever you want to share with. And then it saves you time with the back and forth from the labs. So how does it work? You visit labtracker.com, go to the laboratory page, you choose the lab that you want to book your test with, and then you select the test, right? And then after doing that, you can prefer, at-home sample collection or walk-in depending on what you want. And then once your sample gets to the lab, you will get your result immediately. It's ready on the lab tracker app. So the question is, why wait? You can take control of your health right now. You can benefit from regular testing because it can save your life, and then it will help you detect health issues early. You stay on top of your health because you have access to all your diagnostic data on one platform, right? And then of course it gives you peace of mind to know your health status every now and then. So visit labtracker.com to create an account and book your test in minutes and enjoy the convenience that you deserve. I joined the program and I heard Dr. Afam. Dr. Afam say something about digital patients, right? So as we all know, the world is going digital. That means medical labs everywhere needs to be connected on a digital platform so users, patients can access these services right from the comfort of their home. And that is why we are building Lab Tracker to make life easier for the patients, for the labs, for the doctors, and every other person involved in taking care of your health, right? So give us a follow at Lab Tracker on X, LinkedIn, Facebook, Instagram, TikTok, and do well to tell your family, friends, and communities about us, right? This is the future of diagnostics. We are building that future together. Thank you.
Thank you very much, sir.
Any question?
Thank you very much, sir. So we all
I can take a
see
few questions.
what Lab Tracker is about. Lab Tracker is one of our sponsors for the EOhealth NiMSA Virtual Emergency Health Training, Emergency Response Training, and we've learned a bit of how Lab Tracker helps diagnostics and helps health testings seamless even on digital platforms. So please, just as we've seen the social media handles from this slide, please let's ensure to follow on Instagram on Twitter, on LinkedIn. Let's ensure to follow massively. And as well, do well to patronize whenever you need, whenever you are in such or your family member is in such. I don't pray that we are in hospitals, but actually we are doctors. So whenever you have patients, you recommend lab tracker to them and ensure that they actually do make use of the application. Thank you very much, everyone. So we'll be moving on to our next speaker, who will be taking us on interdisciplinary collaboration in healthcare. So I'll be reading a citation in a jiffy. Please give me a moment. So taking our next speaker citation, Dr. Unamdi Okoro is a distinguished physician and a public health expert. Born on the 7th of December, he obtained his MBBS degree from Imo State University, Owerri, in August 2011. His passion for advancing community health led him to earn a Master of Public Health from Obafemi Awolowo University, Ile-Ife, in November 2021. He is a fellow of the Medical College of Public Health and Community Medicine, FMCPH, as well as a fellow of the West African College of Physicians in Community Health. Dr. Okoro began his career as a house officer at Federal Medical Center, Irutemeta, Lagos, and went on to serve as a corporate doctor and later as a medical officer at Dideolu Specialist Hospital, Ogun State. He completed his residency in public health and community medicine at the Obafemi Awolowo University Teaching Hospital Complex, where he honed his skills and deepened his impact in the field. Currently, he serves as a lecturer and consultant in community medicine at Babcock University and Babcock University Teaching Hospital. Driven by the core values of diligence, excellence, and the pursuit of reaching the zenith in all his endeavors, Dr. Okoro continues to make significant contributions to public health education and practice. His work experience, we can see that he served as an house officer intern at FMC Butemeta in Lagos, Corporate Doctor Dideolu Specialist Hospital, Ogun State, Medical Officer Dideolu Specialist Hospital, Ogun State, Resident Doctor in Public Health and Community Medicine, Obafemi Awolowo University Teaching Hospital, Lecturer stroke consultant in Community Medicine, Babcock University Teaching Hospital, and his goals are diligence, excellence, and zenith. With a virtual round of applause, please let's welcome Dr. Unamdi Okoro as he takes the stage. Over to you, sir. You can unmute yourself and speak, sir. Please, can you hear us, sir? Can you hear me, sir? You can unmute yourself and speak, sir. Sorry, please. Sorry, please. I don't know if we can hear me. If you can hear me, please react. Okay, so right now we are having a bit of technical issues with the speaker. Is trying to come on. So please let's just exercise a little bit of patience. It's going to The issues are going to be
Oh, okay.
sorted as soon as possible. So we are on now.
Okay,
Thank you. Over to you, sir.
okay, I think I'm on now. Can you hear me, Favor?
Yes, I can hear you, sir.
Okay, thank you very much. I'm sorry for the little technical issue. I initially joined as a viewer, so as a viewer, I couldn't unmute my mic, so I had to join or rejoin as a facilitator. Okay, good evening, everybody. And it's a pleasure to be here. I thank Emmanuel and Sammy for giving me the opportunity. Thanks for having me. And I also thank the speakers before me. They said quite some interesting things. I've also picked one or two things. Learning is a continuous process. It doesn't matter what level you are, you continue to learn and learn. Okay. So we'll just go straight into it. Okay. For the sake of time. So I'll be talking about interdisciplinary collaboration in healthcare. Okay. Why is it important? And this will be the outline. Okay. It's going to be a short one because well, I know students don't really like very long lectures. Long lectures at some point going to get a bit boring. So I'll just go straight into it, okay? All right, so we're health workers, and the health sector has different disciplines and professionals. Why is it important that we should collaborate? What does it mean to collaborate? So interdisciplinary collaboration in healthcare is a situation where the various professionals in healthcare work together, okay? So they're all working together to provide holistic and comprehensive care to patients. So this is very important, okay? And in the process of doing this, these professionals, these healthcare professionals, okay, whatever their discipline is, would have to bring their knowledge and their skills to bear. So the doctors, the nurses, the lab scientists, the pharmacists, they all would bring the knowledge they've garnered both from school and otherwise, and then the skills they've also garnered as they've done their as they've gathered over the years as they've been doing their jobs. Okay, everything is brought to bear so that the patient gets good care, quality care, the best care possible. The collaboration may also involve non-medical staff. So it's not just the doctors and the nurses, the lab scientists. It may also involve people who are part of the process, but they may not necessarily be medical staff. Okay. An example is the driver, the ambulance driver. I mean, you can imagine a situation where maybe you need to refer a patient urgently. Maybe let's say a patient who came to a general hospital and is beyond what they can manage there, and they want to move the patient to a teaching hospital. It's really urgent. The patient needs to get there in minutes, and the ambulance driver is just not there. And let's say it's in the middle of the night where you cannot get a cab or a tricycle or even a bike or something, and maybe the people may not be mobile themselves. If it is a patient who is mobile, they can say, okay, let's go with the patient's car. But let's say it's a patient who doesn't have a car, is in the dead of the night, and they've brought this patient, and there's actually an ambulance to take the patient, and the driver is nowhere to be found. I mean, the chaos it's going to cause. A few times it has really caused chaos, okay? So the point I'm trying to make here is that everybody is important, even if it's the non-medical staff, provided all of them are part of the process for caring for patients, okay? And as we all know, the end point of patient care, or the end point in healthcare, is to ensure that our patients get the best care possible. And for our patients to get the best care possible, the different disciplines in healthcare will just have to collaborate. There is no other way around it. All right, so who are the professionals in healthcare? These are just a few examples: doctors, nurses, pharmacists, medical laboratory scientists, physiotherapists, radiotherapists, health attendants, health information managers. The health information manager, usually initially we're calling them medical records officers, but they said, oh no, we're no longer medical records officers. Okay, we want to step up. So they said, we're no longer medical records officers, we're now health information managers. So we said, oh, okay, if that is what you want to be called, if that is how you want to be addressed, no problem. So health information managers. Then, like I said, the example I gave, the ambulance drivers, the morticians, the clinical psychologists, dietitians. The list is not exhaustive, but this is just parts of the professionals in healthcare which you are aware already. Okay, so what are some of the roles, okay, that healthcare workers would have to perform? The reason I'm bringing this up is to tell us that every healthcare worker is important. Everybody is important. Like I said, even the ambulance driver, because while I was doing my residency, we have the community medicine extension where we also offer, do some level of general care. Okay, a few times they brought patients to us that we had to refer the like I said, in the dead of the night, and we couldn't find the ambulance drivers. It caused a lot of trouble, really. Okay, so the point is that everybody is important and nobody should be taken for granted. Everybody should be respected. Okay, so the outpatient, okay, the patient who is coming and going and isn't going to be admitted, what are some of the responsibilities the health worker would have to perform, or the health workers in the different disciplines would have to perform? We need the health information managers to get them registered and obtain a folder. It actually has to be them. In fact, the way that art is created, I'm not sure anybody can do it well apart from them. You may attempt to do it, but honestly, there will be lapses if you're not a trained health information manager. Then the initial assessment, the triage, and then the checking of the vital signs, and then getting them ready and organizing them to see the doctor. That is done by the nurses, as we are aware. Then the medical consultation is done by the doctors. Then if the doctor wants the patient to run investigations, they would have to go to the laboratory, and that will be done by the medical laboratory scientists. Then after that, they will go to the pharmacy for the dispensing of their drugs, oral or parenteral. Now, if there are parenteral drugs, for example, injections, that would have to be administered by the nurses. If there is any other procedure the patient may need, let's say a patient who needs suturing, a patient who needs IND, or any procedure at all, depending on what the patient has, that will be done by the doctor. If it is wound dressing, it will have to be done by the nurses. Okay, so you can see these are various responsibilities done by various disciplines in the healthcare sector. Everybody working together. So, like I said, everybody is important and nobody should be taken for granted. What about the inpatient? That is a patient that is to be admitted in the ward. It's actually a doctor that would give the order to admit a patient. As a matter of fact, I'm not sure any other medical worker has that authority to admit a patient. It has to be a doctor. Okay. Now, the doctor gives the order to admit the patient, and then it is the doctor's responsibility, the onus is on the doctor to review that patient every day, sometimes even 2 times in a day, depending on what the situation is. And then the instructions that are given by the doctor will be carried out by the nurses. So the close monitoring, okay, the way the profession is, the doctor would come, review the patient, and then go because he has other things to do. Then it is the nurse on duty in the ward, that is in that ward, that would have to monitor the patient very closely, ensure that the patient is okay, ensure that the patient, get their medications, their injections, their drugs, and every other thing. Then if they need the doctor, they can invite him, and then he or she comes over, sees the patient, gives the instruction, or performs any procedure he wants to, and then leaves. But for the very close monitoring of the patient and then ensuring that they get their treatment real time, that is done by the nurses. Now, if they need any assistance while in the ward or issues of hygiene in the ward, cleaning, washing, and ensuring that the ward is clean. That is done by the health attendants. So you can see even the health attendants are important, because if they're not there and everywhere is looking so messed up, so soiled and so filthy, you wouldn't even want to stay there. And if there is anywhere that should be very clean, it is the hospital, so that we don't give patients nosocomial infections. Okay, so even the health attendants are very important. Okay, because they are the ones that clean the whole place and ensure that the place is hygienic, and that we don't give patients all their infections they didn't come with from our filthy environment. That should not be. Then okay, if they have investigations they are to carry out in the hospital, the health attendant also moves them from the ward to the laboratory. Okay, maybe on a stretcher, or well, usually on a stretcher, or maybe on a wheelchair or something. Okay, so the health attendant will move them to the lab, and then they will do the test, and then the health attendant brings them back to the ward. Or if it is a test that's to be done outside the hospital, such that they would need a means of mobility to go do the test and come back, that would have to be done by the ambulance driver as well. Okay, so we've had a few situations where patients need to go out to do investigations. Okay, so the driver will take them, and then they will go for the investigation that probably that is not available in the hospital, and then after the investigation the driver brings them back as well. Okay, so like I said, these are some responsibilities, so it's just to prime your mind that these responsibilities are very important. Each person has their own responsibility, and it's important that they all do it and do it well. Okay, now what are the benefits of interdisciplinary collaboration in healthcare? It reduces waiting time, especially for the patients. Very important. As a matter of fact, waiting time is one of the indices for patient quality of care. Okay, so it reduces waiting time, I beg your pardon. So you can imagine a situation where patients come to the hospital and every health worker is up and doing. Okay, they know their responsibilities and they are doing them on time, real time. Okay, they wouldn't stay long, but by the time they come, the health information manager is not there. They will wait for 1 hour to get the card. Then they get the card and the nurse is not there to maybe check the vitals, or maybe the nurse has checked the vitals and the doctor is not there to consult, and they are waiting, or the doctor has seen the patient and has sent for investigation, and they get to the lab and the lab scientists are not there. You can imagine how much extra time they would spend, time that they would not have spent if these people were at their duty posts. Okay, so it also improves the quality of care to patients. Okay, so patients get the right quality of care that they're supposed to get. Okay, because every worker is doing their job, the way it is supposed to be done. They're carrying out their roles and responsibilities the way it is supposed to be done. And by the time that is done, invariably it will increase the quality of care that the patients would get. Okay, then it also increases patient, or it improves patient outcome. Okay, after treatment. Okay, so a patient who came with a particular ailment, okay, and then was treated and was treated properly, okay, by health workers that are very diligent and very meticulous in their duty. And then a patient who goes to another hospital with the same ailment, but the health workers there are very lousy, very lax, with such lackadaisical attitude. Of course, you can be sure the outcomes would not be the same, despite the fact that the patients went with the same ailments. Okay. In fact, it's been noticed that if health workers do not do their jobs and do their jobs to the letter, you can lose patients, and those will be losses that would have been totally, totally unnecessary, losses that would have been preventable if only the health workers were up and doing their jobs properly and are at their duty post when they are supposed to be doing their jobs. Okay, so it is really important. And then it also makes patients satisfied. Of course, by the time they come, they're not staying so long. They get their cards, the nurses attend to them, the doctors see them, they go to the lab, they go to the pharmacy within minutes, or I can say minutes really. Okay, and maybe let's say in 1 hour or even less, the patient would have gone through all the channels and has been attended to. They have their drugs, they've been given their next appointment. Okay, it will increase patient satisfaction. Unlike when they come to the hospital and they're going to spend 6 hours. Okay, some patients have complained that any day they're going to the hospital, they don't do any other thing for that day. They don't fix any other appointment for that day because they will spend the whole day in the hospital. Ideally, it shouldn't be. I understand that, yeah, some hospitals may have very high load of patients, the health workers may not be that much commensurately, but all the same, if we do the best we can, we may not be able to reduce the waiting time to the very barest minimum, but at least we would still be able to reduce it significantly. So even if the patients are so many and the health workers are few, but even the few health workers are up and doing, and the patients see that they're actually doing their work and they're working very hard to attend to them, and they themselves will equally admit that, oh, we were so many, but the health worker, they tried, they were really up and doing to attend to all of us. Okay, so that even if they waited a bit longer than they expected, they would not complain usually, especially if it's patients that want to be reasonable. They would not complain. Okay, because they would see, I've had situations where I was the only doctor on duty and I had like maybe 50, 60 patients waiting for me. And I'll just tell them, calm down. I will see all of you, but it will have to be one at a time. And then I'll try not to spend so much time on one patient and all of that. By the time I'm seeing the last patient, okay, the patient may have waited for 2, 3 hours, but the patient will say, oh, doctor, you really tried. I mean, I saw how you were running up and down. It was just you and all of that, so we really appreciate. So it's really important. Okay. Then it fosters innovation. By the time health workers collaborate, okay, and they bring ideas, sometimes health workers have brought very good ideas, okay. I mean, I remember while I was doing my house job, there were some good ideas in the theater while we were operating that were actually brought by the nurses, okay. I mean, situations in patient is on the table and then the doctor, the surgeon, has an issue and he's like, oh, okay, how do I do this? Okay, let me go this way. Okay, let me do this. And then the nurse says, oh, okay, sir, okay, how about we do it this way? Okay, maybe this way. Oh, okay, let me try that. And he actually tried it and it worked out very well. Okay, so it doesn't matter that it's a nurse and somebody would say, oh, why should I listen to her because she's a nurse? Okay, but by the time healthcare workers are working together, you would realize that it's really foster innovation, and by the time these innovations are applied, it's really make patient care better. Okay, and then it reduces friction amongst health workers. Very important. All right, next slide. Okay, then okay, so what are some of the challenges of interdisciplinary collaboration in healthcare? We've had situations where healthcare workers have ill feelings towards each other for reasons of, number one, remuneration, for reasons of even how much training you received while in school, and then for reasons of the positions that different health workers occupy. So we've had nurses complaining that why should a nurse earn less than a doctor? That nurses should earn the same salaries as doctors. And for God's sake, that is not done anywhere. We make them understand that you would earn the salary you're supposed to earn deservedly as a nurse, but you cannot say you should earn the same salary as a doctor. It's not done. I mean, what are you talking about? And then the next thing they will say is, oh, is it because of whatever training you got while you're in school? Was mine any less? Some of them have said that. I remember then when we started our house job, depending on how much we were being paid then, some of the nurses were very, very upset because they said, look at these little children, little boys, little girls, silly people. Look at how much they're paying them. I'm a senior nursing officer. I'm a principal nursing officer. I'm a chief nursing officer. Do you know that the salary of the house officer is higher than mine? How dare they? What training? Me, didn't I also go through training? And okay, who said doctors should be CMD? Nurses can also be CMD of a hospital. Why should it be only the doctors? Oh, please. I mean, by the time we start nursing such ill feelings towards each other, it's a big, big challenge in collaboration. Okay. Now we have cultural differences. Yes. Okay. Sometimes cultural differences, maybe not all the time, but a few times. Okay, I remember there were some nurses that came, okay, while I was in Ife, right? There were some nurses that came, I think some from the east and from the south. They were posted to Ife to come and serve. Okay, I mean, yeah, NYSC. So they came, and usually if they see those very old matrons, okay, well, let me not say very old, these senior matrons, okay, I think that's better now. So those senior matrons, they greet them. Oh, they greet, it's not as if they didn't greet them, they greet them, okay? But those matrons got very upset because they said they must kneel. And okay, these are people coming from places where actually we don't really kneel. I'm from the east. we don't really kneel to greet people. You may, but it's not really. It's not a how do I put it? It's not a regular part of our culture, really. You can greet, you can genuflect, you could bend a little. Then maybe for men, you can, like, if I want to shake my father, I'll shake him with two hands instead of one, and then I'll bow my head, that kind of thing. But for ladies, especially here in the West, they kneel, and those matrons insisted that those nurses must kneel to greet them. How dare they? I don't care where they're coming from. Don't they teach them respect? Silly children, disrespectful children. And they just complained and went on and on. The case came to us, and for the sake of peace, really, for the sake of peace, I had to talk to my sister and say, please, if you see any of those nurses, please kneel and greet them. It won't take anything away from you, just for the sake of peace, okay? You'll be here for just 1 year and then you would leave, okay? So please, they're the ones that will fill your forms, they're the ones that will sign you out, they're the ones that will grade you and all of that, okay? So please, if they want you to kneel and greet them, I know it's not in our culture, but please kneel. And then they had to start kneeling, and actually that took care of the problem. At least that took care of the problem, okay? So cultural differences. Then communication gaps, okay? Health workers should learn to communicate. If there is any problem, please speak up. Don't get your emotions bottled up. It can get really explosive when the person now lets it out, okay? So please, communication. If you feel there is anything that isn't going on right, or something that is done that isn't supposed to be done, speak up, okay? Let us talk to ourselves, okay? If the nurses feel a doctor disrespected them, we told them, please, if you feel a house officer disrespected you or a registrar, please come to us. Or even in Babcock here where we work, okay, come to us. We will look at the issue. We will look, dispassionately, and if it is something that the doctor misbehaved, depending on the level of misbehavior, we may have to discipline him depending on what it is. And then if it is something that we say, okay, please just say I am sorry, and the doctor says I am sorry, and that is it. And in most cases, we realize that the doctors didn't do anything. Actually, the nurses were just being funny, and then in that case, we just say, okay, fine, please make sure it doesn't happen again. Okay, all right, sorry, oh, sorry. Are you okay now? All right, yeah, sorry now, oh, sorry, and stuff like that. So we tell them, please speak up, okay? Don't just bottle things up, speak up. And whenever you speak up, then the matters are addressed, and then we know how best to take care of them, okay? Then burnout amongst healthcare professionals. Most healthcare professionals are burnt out. The stress is so much, like I said, some hospitals handle very massive, number of patients, and the health workers are not enough, so by the time you come to work and you're so stressed out, and I mean so stressed out, if it is somebody who isn't able to control their emotions very well, you find out that the next thing they begin to vent, it happens both among doctors, nurses. What is your problem? They're shouting at the patient. Nurses tend to do that a lot. Doctors do it too. Or maybe you get to the lab and the lab scientist says, hey, stand out there. Don't come in here. Can't you see I'm busy? Wait until I tell you to come in. Or they go to the pharmacy and the pharmacist says, hey, please, there are 2 people here already. Every other person, stay out. Come on, get out. And they're screaming and shouting. So by the time they do that, even to the patients, most times we do it to ourselves too. I mean, even as health workers, because we've had situations where we went to the lab to talk to such people, and even to the pharmacy, and they raised their voices at us. Of course, we had to take it up. And then at the end of the day, it's, oh, I was stressed, oh, I was tired, oh, I'm sorry, I wouldn't do it again, and stuff like that. Okay. So when health workers get burnt out, okay, sometimes it can also bring friction, okay, it can bring challenges in healthcare collaboration, okay. Then we have lack of trust, okay, a situation where health workers do not trust themselves. In fact, for me, that shouldn't be an issue, okay, because I don't see why health workers should not be able to trust themselves, okay. But sometimes health workers do not trust themselves, and I may not, okay, I may not blame them, depending on what the previous experiences were, okay? Because, okay, like when I was a house officer, there were nurses, okay? I'm sorry to say this, but I mean, I have to say it. I mean, there were nurses that were really out to put doctors into trouble, as in deliberately, intentionally, on purpose, So as a house officer, then the worst thing that can happen to you is there is a line for you to set. and especially if they've sent the information out that you should come and set the line, and the line is not set, oh Lord, or a sample that has not been taken, or a lab investigation that has not been retrieved, okay, or they need you for something and you are not there. Oh Lord, a lot of house officers got into trouble. Some they were able to get out of, some they were not able to get out of because of the way the nurses went and painted them black to the management. Some of them got extra months, of posting, and those extra months is without pay. So I had to talk to myself, and I had to talk to my colleagues, and I'm talking to you now. Please, by the time you become house officers, and even throughout your practice, I also try to do that even now. Please ensure you are punctual. Okay, don't give a situation where they are looking for you and they can't find you, and especially if there is no good reason. They could be looking for me at the ward and I was at the A&E. Of course, by the time I tell them I am one human being, I cannot divide myself. I was at the A&E and they confirm I was at the A&E working my life out. Of course, that settles it. But a situation where they needed me at the ward, I wasn't there. I wasn't at the A&E. I wasn't at the lab. I wasn't at the clinic. I wasn't at the theater. I was just nowhere to be found. And everything I was supposed to do, I have not done them. Then at one point in time, I had to read the reports they wrote. They write a lot of reports. It was amazing what they wrote in those reports, and I was like, my God, really? So I tell people, please, but there are those of them that are just objective and don't really have time for all this, silly behavior and all that. They just come do their work, off they go, and that is it. But there were those, like I said, that were just out to put people into trouble. Please do not play into their hands, okay? Please make sure you are at your duty post. Make sure you are punctual, okay? If there are any procedures you need to do, ensure you do them. And please, whatever you do, document it. Some actually went, did what they were supposed to do, but did not document it, and that stood against them. So please document it, okay? Please, let's not play into the hands of people who may not have good feelings towards you. Unfortunately, they exist, okay? Well, some say it's on the decline. I hope it's on the decline. But please, by the time we become house officers, please, like one of our professors used to say, be very careful with your patients, okay? He said your patients are your best friends and they're your worst enemies. Not just house officers, every doctor really, okay? Be very careful of patients and be very careful of fellow health workers, especially nurses. I think he had his reasons for saying that, and everybody laughed and said, "Oh, why should he say that?" It sounded a bit unnecessary, but actually, by the time I did my house job, I understood why he said most of the things he said, because, like I said, most of those nurses were really out to just put people into trouble. Okay, now we have attitude amongst health workers. That is not right. Okay, some doctors are guilty of that. We look down on nurses, we look down on pharmacists, we look down on lab sciences, where sometimes some doctors are so rude to them. I've also had colleagues that were like that, and I had to tell them, please don't do that. That even the other health workers too, they have attitude amongst themselves too. Okay, please, let's not look down on anybody. As you can see, all those duties were listed. If you're to do yours and another person's own, it will add to your stress, and you may get burnt out and all of that. Okay, so please let us not treat each other with attitude. We all have our trainings, we all have our jobs. Let's just do our jobs dispassionately and put the attitude aside. Then we have lopsided rewards, incentives, and in-work trainings. Okay, so trainings that they get while they've already started working. So a situation where maybe the only nurses are going for training, or maybe only doctors are going for the training, or only pharmacists or something, and then a group of health workers are excluded from such trainings. Okay, it can bring about ill feelings in them. Okay, and then some health workers are rewarded for good work and others are not. That can also bring about ill feelings. Okay, so in situations like this, please, the rewards, the incentives, the trainings, the bonuses, everything, it should go round. Okay, please, everybody should get them as much as possible. Next slide. Okay, so what are sorry, just a minute. Okay, so what are the ways to improve in interdisciplinary collaboration in healthcare? adequate communication and dialogue. I've talked about that. We just have to dialogue, okay? We are human beings, so once in a while there will be issues. There are issues between couples, there are issues between siblings, okay? So if even couples and siblings can have issues, is it two people, two very different people that are just working somewhere? So as human beings, there would always be issues, okay? But the most important thing is that there is communication and dialogue, and these issues are handled objectively and the way they are supposed to be handled and on time before things degenerate further, okay? Mutual respect, I've talked about that. Please, let's not look down on other health workers. Do not allow other health workers to look down on you too. Some people do that, okay? So mutual respect for everybody. By the time the doctor respects every other health workers, okay, all the other health workers, and then the other health workers also respect the doctors, and it vice versa, it goes that way. So everybody should be respected. Objectivity, let's put aside sentiments and issues. I mean, a situation where something is white, but for primordial reasons and for silly reasons you say no, it's black. No, 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 that's not right, okay? So we need to be objective. It was the same nurses that went and told their colleagues that, what are you people doing? We cannot earn the same salary with doctors. Let us be objective. We don't even earn the same salary with pharmacists or lab scientists. How can you now say you want to earn the salary of a doctor? You're not a doctor. The trainings we had are different. And then some will call them saboteurs, call them traders, and call them this and that, especially when they go for their Johesu meetings and all of that. We've had some of them who told them, please, let's just be objective. These things we're asking for are not right, and we're just causing trouble that shouldn't be. Okay, so as the issues, as we're communicating, as we're having our dialogue, and as the issues are being addressed, let us be objective. The doctor, the nurse, the pharmacist, everybody, even the management, the administration, everybody should be objective. If we're all objective, honestly, dispassionate, we will have less problems because we will all know what our limits are. Okay, then clear roles and responsibilities. Everybody should know their roles and their responsibilities clearly, and then keep to their limits. That's one thing. There are limits in healthcare, for God's sake. Everybody should do their work, okay, carry out their roles and their responsibilities, and keep to their limits. If that happens, like I said, we would have less problem, we would have less friction, okay? Then, like I said, the rewards, the incentives, the trainings and bonuses and everything should go round, okay? It's not good that some people are getting it and others are not, so it should go round, okay? And then health workers should be treated well by their employers, okay? Because most times if health workers are not treated well, and then they get burnt out, or they are very obsessed with their work, they are not happy, it manifests in their work. And then the next thing, like I said, they begin to vent it out on fellow health workers, they begin to vent it out on patients, okay? But if health workers are well taken care of, I think it will make things easier and better, okay? Yeah, I think that's the end of it. All right, so in conclusion, interdisciplinary collaboration in healthcare is essential to the provision of quality care to patients. When there is friction amongst health workers, the patient are the ones that bear the brunt, okay? The saying that when two big elephants fight, it is the grasses that would go flat under them, okay? And then there has to be adequate communication and dialogue. Dialogue has solved a lot of problems, you see. The problem with people is that we're not ready to dialogue. Even wars that have been fought, some of those wars would have been avoided if only there was dialogue. But because people are not just ready to discuss. And like I said, when they are having that dialogue, please be objective, be dispassionate, okay? Health workers should treat each other with mutual respect, carry out their roles, and keep to their limits. This is very important. Health workers should be treated well. Every health worker is important. Nobody is less important, okay? So please let us do our jobs. Let's be careful, and let us keep to our responsibilities and our roles, okay? And by God's grace, everything will be fine. Thank you. Okay,
Thank you
I'm
very much,
done.
sir, for the insightful teaching and session. Yeah, it was very insightful and very, very practical. So we'll be going on to our question and answer now. But before then, I think I have a question, and during the session, it drew my attention what you said in particular about the doctors kneeling to the nurses just for peace to reign. Hmm. I think personally, it's quite a concern. Like, why do they have to like create a problem over a cultural issue? If they are going to practice outside the country, there's no way anybody is going to kneel to greet them. So why was it not directed to their head to maybe caution them, and rather than making the doctors get subjected to having to kneel to these nurses just for peace to reign? That's my question. Then we'll go on to answer every other person's question.
Okay, well, it wasn't doctors. No, of course. Why would a doctor kneel to greet a nurse? I mean, let's face it. That for me, that's not even right. It was nurses. Like I said, nurses that came to the teaching hospital for for internship and for NYSC. Okay, so some of them came from the southeast, some of them came from the south. So, like I said, and for us, it's not really in our culture to kneel. So it was nurses, please. It wasn't doctors. Of course, it wasn't doctors. Okay, so it was the nurses. Now, those senior matrons got very angry, like I said, and they were very unfair. They made life very difficult for those ladies. I mean, ugh, it was taken up by their head, and they said, well, this is west, this is the west, okay, and we understand. Someone also brought up this issue that if you're abroad or something, who will kneel to greet you? Oh, of course, who does that? Okay, but they say, yeah, that is abroad, this is Nigeria, and this is Yoruba land, like they would usually say. And they would send those nurses, to for some, let's say if you're to be in the labor ward for 2 months, they will put them there for 6 months, and they will just remain there. For some, they will send them to burns units where, in fact, you dress wounds 4 times a day, and in fact, you're the one that will pack the stained beddings and everything. Then the attendants will now come and take them to the CSSD to get them washed and all of that. So we noticed that they were also, being very unfair to those nurses. And for me, I was like, what is the problem? We had to go to, they said, come, what is the problem? And they said, oh, they are being disrespectful. They greet us and they don't kneel. For those of them that were doing NYSC, they said, okay, let's just do the NYSC and go. Okay. But for those of them that were doing internship, some of those nurses were the people to, mark their forms and grade them. You won't believe it. The initial forms they filled, they marked them down. And with those grades, they gave them 20, 30, over 100. By the time it gets to the nursing council, they will not give you a permanent license. In fact, they may even ask you to go repeat the internship just because someone did not kneel to greet you. And in fact, for that one, we had to take it up and say, no, we cannot send this. They should either regrade them or give it to another person. And then they said, okay, oh, no problem. Another, I think another senior matron now graded them, of course, graded them objectively because those nurses did well, and then they left. Another set came in, and this issue of greeting and kneeling came up again. So we just said, okay, for the sake, for me, because the whole thing became an official issue. So it's not as if we couldn't take it up officially to the very letter and say, okay, it will never ever happen. For me, the back and forth was just becoming too annoying for me. So I just told them, okay, please, for peace sake. Of course, there are some situations where I can say for peace sake, but there are some situations where I will put my foot down and say, no, this is what it should be, and this is what it just has to be. Okay. We had issues like that where this one, it was doctors that had issues with the nurses, and we took it to the very end and made them, in fact, we put them in their places. Okay. But for this one, we just said, okay, for the sake of peace. So the new people who came in will now kneel to greet them. And their attitude changed. They became so nice. They became so friendly and everything. So it depends on what the situation is. It's not a one size fits all thing. Okay. It just depends on what the situation is and how best you think it can be taken care of. Like I said, there were some that we insisted and we followed it up, but there were some that we just said, okay, well, just for the sake of peace, just let it go. And so they just did it, and that was it. Okay, so it's just a situation. It's a situational thing. Okay, all right.
Thank you very much, sir, for that response. So we'll be going on to the next question. If you have any question, please kindly raise your hand. By the way, I think I forgot to ask us to use our emojis again to appreciate our speaker. It was a very insightful session, yeah, and very practical. So do we have any more questions? Please raise your hand if you have a question so I can grant you access. Okay, I don't think we have any more questions. So in the absence of any more questions, we'll be bringing our this session to a close. But before then, I would love us to connect with our speaker with the handles that is currently being displayed on our screen. Make sure you reach out. You can send a mail, you can connect with him on Instagram, connect with him on LinkedIn, and make sure you make adequate use of the connection. So with that, we are bringing the session to a close today. Want to say a big shout out to our first speaker, Dr. John Afam, and our second speaker, Dr. Okoro. We really, really appreciate your teaching, your insights, and yes, this has been a time well spent. We also want to say a big appreciation on behalf of Emmanuel Olabi, the convener, and the programs coordinator, Samuel Olalekon. We say a big thank you from the team. Thank you everyone for joining today. Make sure to join, engage on the group, connect with every of our speakers, and make sure to set your reminders for next week's session. Don't forget to join, don't forget to anticipate, and also don't forget to reach out to these people and also engage your social media, engage your LinkedIn, whatever you've learned, you can send it on there, get engagements, teach others, ask questions, in fact, and I really do pray that everything we are learning will be of maximal use for us in our future. Thank you very much, everyone. Do have a lovely week ahead. Good night.